This week on the BackTable podcast.
I think, first of all, get help, go and see people, try to see if that's the right practice for you. If you think that you like the idea, do it, because you will always regret if you don't do it. And especially some people say, oh, Jafar, at your age, it's good to do it. Actually, I would say no. If you are younger, it's better because you have 50 years to catch up with the dead or anything. If it fails, I have just few years. I really recommend that if you want to go into this and start right away, get people around you to help you with the negotiation with the insurance. That's the most important.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor. This podcast is brought to you by GE Healthcare's Interventional Allia platform, your trusted assistant for image-guided therapies. With Allia IGS-7, they've introduced a new member to the interventional suite, present when and where you need it. With its mobile robotic gantry, Allia IGS-7 brings precise and predictable motion through its laser-guided positioning. This means free and versatile motion on the floor, eliminating the need for overhead rails and allowing for head-to-toe coverage without moving the table. To learn more, visit gehealthcare.com. Now, back to the episode. Hello, everyone, and welcome to the BackTable podcast. Got another great episode today. We've got recurrent guest, Jafar Golzarian. Jafar has been on the show a couple of times previously, going way back to episode 85, where we were talking about genicular artery embolization, early days. That was probably like 2020, I think. It was around COVID, from what I remember.
Around COVID, yeah.
And then more recently, episode 361, you came on to talk about endovascular treatment of hemangiomas, liver hemangiomas. Right? With Baratza.
Yeah, that's correct. Yeah.
Yeah. So,
and percutaneous ablation.
Percutaneous ablation. Yeah. So, everybody go back and check out episode 361. Episode 85, there's been a lot of progress in GAE since then. So, Jafar, I just had Mark Little on the show last week to talk about updates in GAE. And we talked a lot about guest MSK and guest upcoming. And so I just wanted to give, throw it out there again, a little promo to our audience to definitely check it. Guest MSK is awesome. It's in Paris. I've been to the last couple of years. A great group of people. Got to hang out with Osman Ahmed this year and got to see you again and catch up.
Yeah, no, it was a great meeting, and everyone who really has done a lot of work on MSK is there. And in next year would be again in Paris, January 17 and 18. But it will be fun.
Fantastic. Yeah, it's a great conference. And, really, I would say interactive and like just a big difference between even last year and this year. It was standing room only this year. It was incredible how much it's grown. So congrats on that. And I'm sure it's only going to get bigger as these MSK procedures get more advanced,
Yeah, these are really interesting procedures, and I think especially when you do them, you see how the patients improve significantly, really immediately sometimes. Very interesting. Of course, there is a lot of work to be done, but it's something that's extremely popular, and people love those sessions.
Yeah, and so when I was there, I ran into you, and we were talking about your recent big changes in your career, moving from being in academics for a long period of time to now in private practice, and saying that you set up an OBL. And it took a little bit of time, and that's what we wanted to talk about today, is that transition, how you decided, why you decided, and then what you kind of went through to get to where you are today. So, but first off, for anybody that doesn't know you, I just want you to introduce yourself, tell everybody where you're at and what your practice looks like today.
Right now, working at an OBL in Minneapolis. I have been the division head and program director at University of Minnesota for the last 15, 16 years at the Department of Radiology. Before that, I was also in University of Iowa, and before that, University of Brussels. For 30 years, I was in academic institutions, and after a lot of research, I decided to leave, and now I've started my OBL with a friend of mine, another great physician, Dr. Astani, and we are based in Golden Valley, in Minneapolis, and the name is North Star Vascular Interventional.
Fantastic. And so it's just the two of you guys.
We are three founders. Actually, Bulent Arslan from Chicago helped us a lot. Both of us, Amin and myself, we are full-time here. Bulent, for now, is still very busy in Chicago, so we don't have a plan right away to have him come and do cases.
Berlin's in academics. You were in academics. How about, sorry, say his name again?
Amin Astani. His last name is Astani, Astani. And Amin has been trained in, I think, in Dartmouth in Michigan, and then he was in Christ Hospital in Chicago. So he's mid-career, very, very skilled interventional radiologist.
And so you, like you just mentioned, you've been in academics for a long period of time. When did this seed get planted in your brain, or this idea hatch where you're like, you know what, maybe I'm going to explore, because you said you researched it for a long period of time. How long did you research that? When did it start? When did you start thinking about it?
First of all, I had this idea for many, many years. In early 2015, 2016, I was thinking about joint venture with other groups, and I have actually discussed with urologists since then to see if there is any possibility to have a joint venture. But the real search for myself started around COVID. When COVID hit, and I enjoyed really the time at home and spending time to do some other fun stuff. And I kind of started to research that and talked to Bulent, went to see a lot of people in private practice. I think after, actually here locally, I went to see Mike Cumming, and he was very kind, showing me around and explaining me the pros and cons and everything. You can't change your personality being an academic physician, so I did not to go and look at all the aspects. And also my personality, I'm not a risk taker in general, which sounds very strange when someone at my age go to private practice. But I started to really study or see if it is feasible, there's enough market here to be able to do that. It came down to, okay, what I'm going to give away and what are the risks. And as I started to put this together, I realized it's something I can do. Then after that, the decision was easy.
So how close are you to the medical center? I mean, were there any issues with a non-compete, getting outside? Obviously, like, you're not taking, you almost got to start over from zero, right? Building a new practice. So once you had the idea and started taking the steps, like, how did you see that unfolding with your separating from your university practice?
So, I have been talking to the chairman for many, many years. Actually, I gave the chairman 3 pro forma for building an outpatient practice at the same time. And, it was not really under their radar. They didn't understand the benefits. But so when I decided to move on and explain the situation, I also gave them all the opportunities, possibilities where this can be their OBL, or we can do it together, or they can invest in the OBL, and or I can go by myself. And I said all of these options are possible. I think it was a little bit hard for the leadership to understand the move, and but I didn't have a non-compete. And I think most places, but definitely in Minnesota, the non-compete is not something that you can act on anymore. I think there is a law against non-compete, which I understand. So no, it was not easy, I would say, to let go, but we have had a lot of discussion. I was a tenured professor, so usually people don't give away tenure. So we discussed about doing some part-time there and have some benefits, but it was limiting my practice in some way that I decided that I'm just going to leave it. But I'm still an emeritus professor, so I go once a month, and my team mate at the U are kind enough to put really complex cases when I'm there. So I have fun when I go back there and do 1 or 2, 3 cases that they prefer to have me around to do that together. So right now I go 1 day a month at the U, and the rest of it I'm at North Star.
That's fantastic. Yeah, I mean, it sounds like a nice collaborative relationship that you have still with the U of M. And you mentioned that you kind of had weighed out the pros and cons of leaving and staying. What were the outstanding pros that really kind of pushed you over the edge? We're like, you know what, I think this is worthwhile, even though I'm late in my career.
I would say the most important thing is your independence. I was division head. Really, my personal schedule was not micromanaged by anyone. I had one academic day, one research day, one full day clinic, 2 days of IR. I could travel however I wanted. So it's not that I was not independent, but the thing is that just for getting a room installed in IR, when you start to look at 15 years old rooms, 17 years old rooms, and then you say, at least if I could make that decision, I can blame only myself to do the right thing or not. So the independence in decision making, I think, was the most important pro. But the other thing that really I liked, and I personally have been in the other side where, wanted to do some tests in an academic institution, in a hospital, or in a private practice, I saw how the patient is center of attention. And, you are the guy at the time. There is no really significant delay. There is no other person that postponed your case, And, the physician can come and talk to you before and after and spend time to explain what happened. I realized actually for those procedures that can be done outpatient, in an outpatient setting, I feel that you can provide a better patient experience. And that was very important for me. I think when you go back, all of us, when we go back and say, why did we start medicine? A lot of time, this relationship with patient and helping others is the main reason we went to medicine. And you realize that this bond and connection with patient is much stronger when you are in a private practice.
Yeah, absolutely. I mean, we talked about it a number of times on this podcast. Even in terms of patient experience being superior in the OBL or in the outpatient setting, you think about even just parking, right? Not having to deal with the hospital parking lot it's like one less hassle for the patient. It could be, whether they're on time or 20 minutes late for their appointment, could just come down to the parking, whether they were able to find parking. And then, just navigating the hospital system, getting checked in, all that stuff, getting herded around like sheep. Patients don't like that. They really don't.
No, and what also, coming to the procedure, one thing, what was amazing, I actually took picture of my staff walking the patient downstairs, going to their car, letting them sit in their car, and then come back. I was looking at that, and, they did it spontaneously, but you will never see something like this in a hospital.
Yeah, no.
And so I was so impressed by that quality and the amount of it's not that I was not receiving comments from patients when I was in academic institution, but here is almost every single patient come back, send us a card, a letter, a post on the internet, and thanking for their experience. It's something that really, at the end of the day, it matters a lot. You feel much better. You come back home and say, I did a procedure. It's a good procedure, but, the patient was so happy.
Yeah. And then there's the whole efficiency piece, and people actually getting the procedure on time and leaving on time and not spending, maybe 2 hours there, not 4 to 6 hours, like their whole day. Like it's multifactorial. And I also wanted to ask you, when you created that pro forma, what procedures did you have in mind that you were going to do in the outpatient setting? And then maybe how has that changed now that you're established and open?
That's an excellent question. When we started to look at this, of course, we got some help from groups that are there. There are some professionals who help you with that. And usually they recommend to do a lot of peripheral vascular, venous. And of course, my reputation for the last 15 years in Minnesota was mostly around PAE and embolization procedures. So we included all of that. But when we started to work, my main referral was from urologists. And So I was very involved with that clinic aspect of the practice. But then we started to look at what can we build, because, you have limited marketing budgets. And so I had to look at this with Amin and see what is the best investments right now with the amount of money we want to put on marketing. And knee embolization and UFE and those type of things came first, because I think there is much more competitive market out there for PAD and venous. And but there are not many focused embolization OBLs out there, not only in Minnesota, but I think nationwide. And so we kind of shifted our business plan toward embolization. And of course, there are some risks to that, as you know. And some of those risks is still some of those procedures are not accepted by insurances, and you have to spend a lot of effort and time to get the approval, the pre-auths and all these things. But at the same time, the market for those patients is more untapped, I would say. So there's more patient out there, and you can do more digital advertisement for those type of patients. So what we do right now is almost exclusively embolization. Now, I have some of my old patients that call me and say, I have treated them for some other thing and they want to come for other stuff. Like I have this week a celiac angioplasty, and, I would have a May Turner in 2 weeks. So those type of things happen. But most of our focus is based on embolization, and we are planning to grow to PAD maybe beginning of next year.
I see. That's great. I mean, it's great to have a focus too, because that is, like you said, that is super important with marketing. When you go out and visit these referring docs' offices and they ask you what you do, having been in that position, when you list like 10 different things, their eyes glaze over and they're just like, there's got to be a takeaway for them. And it's like, if you say, okay, well, I do prostates, fibroids, and, knees, then they're like, okay, that he's the prostate, fibroid, and knee guy, right? He embolizes.
I think it's a very good message, especially for family doctors.
Yeah.
You don't want to overwhelm and confuse them with all the things you
Yeah, because a lot of them don't even know what interventional radiologists do. they're not in the hospital, so they don't have much exposure to us. You know what I mean?
But yesterday we have a group of PAE doc on WhatsApp, and we send messages together. Yesterday, I think Tim McClure was at AUA and gave a lecture, and there was a picture of him saying PAE is an alternative. And so we started to send those together, and then 2-3 urologists sent me a text about a copy of that paper. It took us, I did the first case of PAE in the country, I think it was 2012, and now it took us 12 years for this procedure to be done. When you talk to orthopedic surgeons, you talk to physiotherapists about GAE or frozen shoulder, they look at you like you are a Martian, and you say, what the heck are you talking about? So there are a lot of these things they don't know what it is, and so it's a lot of effort and explanation and discussion. But I think you are totally right. You need to focus first on what you first of all love and what's the opportunity in your market.
Yeah, because I mean, if you think about PID, for example, or even venous disease, there's a lot of people competing for those cases, especially in interventional cardiology and vascular surgery, and there's already familiarity with those specialties, especially from primary care. So for you to go in and say, I do these 10 things, and it just makes it look like you dabble in a little bit of this, a little bit of that, and that's not a good look for us. You know what I mean?
Absolutely. I think little by little you can build that practice. I love PAD. That's what made me go to IR. Many years ago, that was the major thing. But you are totally right. The people don't wake up in the morning with leg pain and say, I have to go see my
No, absolutely not.
That's the problem.
Yeah. Well, going back to some of the initial decisions that you made in terms of, like you said, there's the limited budgets, especially when you're first starting out. In terms of real estate, did you guys decide to purchase a building or land, or are you renting to start? How did you make that decision?
It's a great question, Aaron. I would say if I have to give an advice, if you can buy. That's definitely the best thing. Now, every case is different. Our situation was that I wanted to minimize the risk. And so I was not very interested to go and ask for few $1 million and then start, because I didn't know how successful I can be, right? So I wanted to go as minimal as possible. And of course, it didn't happen. But again, I was planning to try to go with least expenses, least loan if possible. And then when you grow, you can look into it. So there are a lot of practices where they start slow and small, and then they go and they acquire a building at some point to expand. I would say for us, the problem was, as I mentioned, was to reduce the risk. So the other problem also, Aaron, that people don't realize, it's not as easy to find an office. And one of the things that makes it extremely long and costly for people who want to open an OBL or ASC is to actually find a location that you like, and is you have to build. That the cost of now building those things are becoming really crazy and much more expensive than what it was even a year ago or 2 years ago. So it's very important for people to know that finding that space is one of your biggest challenge, and nothing can start before you find that space. You can do a lot of things, but really when you want to start to get your negotiation with insurance started and everything, all of this has to happen when you have that building. And I know some practices, they spend like a year before they start to find where they can even build. So I would say if you have the money and you have the time, acquiring is always best thing to do. But if not, you can go faster. You want to go faster and less risk, I think renting is the best option at that time.
And then along those lines, I mean, in terms of capital equipment and products for the lab, how did you guys decide on your, C-arm versus fixed unit? I mean, those are big decisions to make. Can you walk us through how you made those decisions?
Yeah. First of all, I may be a little bit biased, or because, being in a hospital, academic institution, thinking for, the cone beam CT and vessel mapping and everything, I really wanted to have a good machine. So they are good C-arm, and I really respect those who work on C-arm, and there are really good quality physicians out there doing mobile C-arm. But we decided very early on to go with the fixed machine. And I have a lot of ideas and explanation why, even financially, this is the best choice. We can talk about that. But then we went to ask for bids from different companies. And in that decision making, the machine itself is usually the same between Siemens, Philips, Canon, GE. But what we wanted also is the softwares that are, making your life easier. And also, it's very important to see who wants your business. And that's extremely important. People don't pay attention to that. Sometimes people get stuck in a $10,000, $50,000 difference, and they go for the cheapest option. But I would say it's extremely important to go for someone who wants your business, because they will stand by you. And so that's why we decided to go to a fixed unit and a good machine, which was, as you may know, is the Allia 7 from GE. And they have been very helpful from, recommendation, helping with software. When you see sometimes difficulties in construction with angio, especially if you are in the higher floor, they have been helping, accommodating some of the things. So I would say my recommendation to most people is to go with a fixed unit. For example, I did a case, 450 pounds patient in my OBL. You can't do that in a C-arm. So you have to refer those patients back to a hospital. And so that's a loss of business. And also, when you have a fixed unit, that fixed unit is considered as a capital for you that can help you get much more loans from companies. And when you are going to raise money, if you need to raise money, again, the presence of that machine in your facility will increase the valuation of your company. It's just all of this. I didn't have an idea when I started that, but I see that really in practice now. And so less patients referred to the hospital, more valuation, and better deal with banks for loans. I think even business, in terms of business, it's better to have a fixed unit, in my opinion.
And the support piece, I think, is also key. And not a lot of, like you were saying, people go for like, what's the lowest cost. But Mary Constantino has been on the show before talking about this, is that if anything breaks down, having that support, because like, you talk about loss of business, your unit breaks down or something happens. And, if they say, oh, we can't have somebody out there till next week, well, you got procedures lined up the whole week. That's a lot of lost revenue right there versus this. You have the strong support where they can send out somebody out the very next morning is key. So those are, I think, it sounds like you're echoing similar sentiments to, Mary and some others that have been on the show. Is just make sure you read the fine print, make sure you ask about those kinds of things like support.
Absolutely. Well, I mean, there is this is extremely important. I think the support piece is extremely important.
And then going back to the software, how did you decide that the software was superior or what you were looking for? Was there something about the software that you were looking for?
So I've been a user of Siemens for many years. I've worked on some other places with Philips, and they are all good machines. But I was looking for ease of use and reliability. And so, one of the reasons in a lot of institutions people have difficulty to use cone beam CT or Embo assist or Embo guidance is, it's training. People, there are a lot of techs, they come in and out and they don't know. And then each time you do that, you don't have patience to wait for this to be reconstructed. And then, so a lot of times you want to do in cone beam CT, you say, you know what, let's move on. But so I started to look at how quickly you can get that, how easily it is. So I went to visit Charlie, Nutting, and Aaron at their practice, Echo Medical in Denver, and I look at other softwares and see how it works. So for me, I think in an OBL, what you want is ease of use. You just don't want to lose too much time for training people. And then reliability.
Yeah, no, that I totally agree. Ease of use and reliability are huge, especially when you're out there on your own. You don't want to be sitting there trying to figure out how to use a joystick. Well, can you tell us a little bit about the layout of your OBL? How many procedure rooms do you guys have? Do you have a pre-op bay, post-op bay? How did you hire an architect to help you kind of do the layout and everything?
Yes. So we got a help from a group that helped us with business plan, with the constructions and everything. We went to ask for. We had the design made and asked for a bid for who would be the person who helped with construction. But we were lucky. We took over already an ASC that was for eye surgery. So there was a little bit of layout there that we used. Basically, what we did, we built another space to be potential expansion to a CR room, a mobile CR room. And then we had 1 pre and 3 post, but we usually can use them in mix them together. So you can say we had 4 bay, and then we decided to go to 3 and then make one of the bay as a nursing station. So we have 2 clinic rooms, a nursing station, then 3 beds for pre and post. And then the angio suite is a really big room with windows, really beautiful. It's a nice space.
I saw pictures on LinkedIn.
Yeah, it's a nice space. When you come over, we'll be happy to show you. And then there is in the back, there is a break room and 2 offices for the docs. And So, and we are already looking at expansion in front of that office. There is another 3,000 square feet space when we start hiring more people. So basically, I think right now 3 pre-post could help us to get to 4 major cases a day. And then if we want to do more, then we need to expand.
Yeah. And so it's interesting you took over an ASC. Did you maintain the ASC status?
That ASC was built before 2018 requirement that have changed. So we had to add, for example, a shower. So I wanted to have some private space for the pre and post. To do that, we would lose the specification for ASC. So we had to change our plan to use the other future CR room as a private space, So yeah, we had a good spend on keeping that as an ASC. And the only thing is for us, when we decide to go for an ASC, is to buy a generator that can keep, I think, you finishing the procedure in a timely fashion.
That's okay. So that's the last requirement to be an ASC. I see. But you guys are still shooting for that. You're working towards that.
We are planning for the fall to look into how is the ASC. And I don't, I have to look at Minnesota certificate of need and those things. So yeah,
it's an interesting conversation, right? I mean, the whole OBL versus ASC thing, and we're seeing so many people considering, converting because of reimbursements. And I don't know if it makes a big difference with embolization procedures, but it seems like it probably does with some more arterial procedures, peripheral arterial disease, and so forth. So I guess we'll just see how it unfolds and whether or not it's worth it, considering what the services you offer, right?
Actually, it's this year the reimbursement for the arterial embolization has significantly increased in an ASC.
Oh, really? Wow.
And it's bigger than an OBL. So yeah, not for the organ embolization, but the arterial embolization. So it's interesting, but I think right now the reimbursement for the OBL, if we get reimbursed, is good enough to run it as an OBL because there are some advantages to do it as an OBL. I think everybody should consider the possibility of probably building it with the ASC specifications in case they want to make them move.
Speaking of that, because we've heard conversations, whether, at conferences and whatnot, it seems like industry has been assisting with docs as much as they can or where they can. You mentioned working with G and them being helpful with the CR, but were they able to help in any other way in that sort of building process and help it make it more, I don't want to say financially feasible, but like, what other kind of resources do they offer to help ease the burden, I'd say?
Yeah. Well, there are some agreement between imaging and device companies, but we of course it's very interesting and we look into it. The thing is that most of these agreements is based on peripheral vascular disease. When you look at the materials, they come with very, very nice ideas how to combine materials and everything. And I think if you are primarily doing PAD and venous work, I think that relationship is extremely important. But for embolization, I have to tell you, most companies, they don't have the act together yet on how to help with those. So, for example, the coils are still very expensive. The detachable coils, there is no pushable coils for a smaller size microcatheter you want to use. Microcatheters that are under 2.4 French are extremely expensive. So, and they haven't figured it out. So the way they have figured out for PAD, they have not been yet prepared, and I say I'd say most companies, almost everyone, still looking at the and ASC as a PAD market or venous market. And that's something, even that I still have lots of good relationship with major device companies. And I talk to them almost every week about these things, and they have not been able to figure that out. So there is not those type of relationship that can help you if you are working on embolotherapy or IO. But, they try to do their best. And there are some companies that are having great materials and they are still with very good price. And some companies, they always brag about their being a premier companies. And so you need to be paying the price. We realize that with those companies, we use them only as a backup.
Yeah.
So in case your first choice doesn't work or second choice doesn't work, then you go to those.
I think theme also when we hear about doctors about maybe the cons of being out in an OBL or ASC setting is just not getting those economies of scale that the hospitals get in terms of, devices and so forth, not being part of a big hospital system. Did you get any help on that? Where is there any outside sort of consultants or advisors help you kind of navigate trying to figure that out in terms of what to keep on your shelf?
Yes and no. So we had a consultant company who helped us a lot on a lot of aspects of building a business, pro forma, business plan, how to find the engineers and the architect to build that space. But unfortunately, I see the same issues with them. They are very knowledgeable about PAD and nothing at all about peripheral vascular. And so the companies that they help us to even bring other, there are some companies like the Amazons of, I don't want to give any name, but they're great. Yeah. They are very good companies, but they also, their knowledge is a lot about PAD. So I think there's an opportunity for the consultant and the device companies to get some expert on board and get some help about how to build a good pricing and what need to be on the shelf for IO, EMBO procedures. The good news is that some of those materials can be consigned, so you don't have to pay for them. But most catheters, microcatheters, wires, everything, you have to pay for them. And that's a very high cost at the beginning of your practice. So very important to really know what you want to do and don't go for everything. Don't buy everything. Start slow. They are usually, the device companies are very kind. They are available. They can bring their truck stock and those type of things. So I think it's very important. You can get some help, but I think a lot of those helps are focused on PAD market.
Yeah. How did you approach staffing? Staffing's always kind of tricky, right? As you know.
Great question. And it is, I was at OEIS, I was talking to a few friends. It's always the same thing. You are, as they call it, you are fat, and then you become thin, and then you need to plan and work to get fat. And so to work with the team to understand that some situation you are too many, and then at some situation suddenly we are overwhelmed and we need to hire, and the hiring will take time. So a study, he has a great vision also. So he started to see, I think we need to start to hire. I say, wait a minute, let's discuss about it. But at the beginning, what we decided was to have one tech and two nurses, and one scheduler, front desk, and then one manager and PA. So, and we were thinking, based on what is the expectation in the market, you will be between 6 to 9 months before you break even, and then you start to look at the next steps. So not that we have been paid at all anything from insurance yet because of all the hack issues that have happened, but we get to the practical number that is suddenly too much for our staff. So we start to think of hiring now. And so we want to hire a few MA, maybe a care coordinator, and one more front desk. So I would say the hiring, you need to look at where you are based on your number of cases and the growth. And if you see that you have continuous growth over 2 months, you need to start thinking about that because it's nothing worse for you to be in a private practice and your staff is overwhelmed and they start to look at something else. And that's really hard.
Right.
The other thing is extremely important is the communication with the staff. I think it's extremely important. We spend a lot of time discussing together. We have a weekly meeting, even if we're a start committee, but start a small group but we still spend a lot of time discussing.
Yeah. The other thing we've talked about before, and Krishna Manav has been on to talk about this in terms of staff, is how important culture is, because a lot of times, Mike Watts mentioned this too, is you can't compete with the salary of the hospital with call and everything. And so a lot of times the staff is really looking for just a better culture. And if you can't provide a better culture than the hospital, then like you said, they're going to be looking elsewhere. So it is really important. It sounds like you guys are, communication is part of that, right?
Communication is extremely important, but also really people, when you talk about mission and vision, a lot of things become like a must do, must have. But honestly, I am convinced that everyone in healthcare, no matter who and which part of healthcare you are, there is deep inside a real motivation of helping patients. So if you build your practice, your team around who are the best people to help patients, and talk to them about that and motivate them to understand that, we are here for a better patient experience. We are here for a better patient care. And they see that. They see the outcome. They see how the patients are happy at the end of the day. So I think that's one of the biggest thing, as you mentioned, culture is that's something that holds a lot of people together. And of course, you just need to be nice with people and not arrogant or be bossy, because you should not be genius to understand that if you don't have those staff, you can't work. So as easy as that, you can. I can go for a week of vacation and nothing will happen. If one of my techs or nurses go, you have to find a way. You can't take care of patients. And I think these are important things. And I think even in terms of salary, you are right that you may not be able to give them the same salary if they were doing call, but you can give them a better salary compared to someone who doesn't do call and weekend. And I think it's a fair game. I think you should. You have valuable people, you need to make them happy. They have to stay. They have to be happy to stay and work with you.
Yeah, it's true. Well, Jafar, we're almost at the hour. I just have a couple more quick questions for you. One is, do you miss anything about academic? Do you miss that academic environment? Is there anything, that you wish you had as part of this practice that you had before?
What I miss is probably some interaction with some of the, so of course, my teammates, I brought every single of them into the practice, and I love them dearly. They're a good friend of mine. So I miss them definitely. But also the interaction with some of the referring physicians. But what I realized that there is, in an OBL, you have that interaction, but it's different. You don't see them every day or, they in some space. But the phone call, they come and visit you, we go and have dinner and stuff. You create some other relationship. The teaching part of it is also something that I missed a little bit, because I have been teaching fellows and some of them are now nationally and internationally leaders in the field. But when you set up a good practice, research and education can happen. You can, I have some of the fellows are reaching out to say, can I come and see how you do a GAE, now that you are with your machine? Or some of the IR physicians across the city want to come and see how Embolization help them. Can they do the same thing? So I think, and again, it's also a question of mindset. I was doing a GAE and I had my catheter into the artery that was showing the blush. And I say, I have never seen how a cone beam CT looks like when you have a catheter in the genicular artery with the blush. So I just did a cone beam CT. It's 2 minutes extra, so it's not a big deal. But at some point, I started to say, well, it doesn't seem like you are, Jafar, you are in a private practice, because this is definitely part of what you do as an academician. But so I think it's a mindset. You can still do a good job and be using your infrastructure and do what you like to do. If you are an academician and you go to a private practice, you can still do a good job and do some research and all these things. So yeah, there are something that I miss, but overall, I think I have never been as happy as now.
That's great.
That's very important.
Well, congrats on that. One last thing is, anybody looking to, maybe you've planted the seed in their brain right now. Anything that you recommend that they start from day one? I mean, obviously building out a business plan and pro forma, but anything else that you can think of to help people that may have been a pitfall for you early on?
Yeah, I think first of all, get help. Go and see people. Try to see if that's the right practice for you, because what is right for me is not right for you or somebody else necessarily. If you think that you like the idea, do it, because you will always regret if you don't do it. And especially some people say, "Oh, Jafar, at your age, it's good to do it." Actually, I would say no. If you are younger, it's better, because you have 50 years to catch up with the dead or anything. If it fails, I have just few years. So no, I think. But the most important thing is to start the negotiation with the insurance early on and have someone helping you with that. And don't trust some of these guys who tell you, "Oh, we are there to help you with that and we know how to do it." Not many people know how to do it. At some point, you become forced to sign a contract that is not necessarily ideal for you. And there are a lot of people out there like this. So I really recommend that if you want to go into this and start right away, get people around you to help you with the negotiation with the insurance. That's the most important thing.
That's great parting advice. Thank you so much, Jafar, for coming on.
Thank you, Aaron. Always a pleasure to be on your show. You have done amazing work with this. BackTable is now a must. Everybody I know, they're driving home, they were driving to work, they are listening to you guys. So congrats.
Thanks, Jafar. We're just trying to catch up to guests,
Thank you so much.
Thanks, everybody.
Bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamilah Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening. Dr. Golzarian is a paid consultant for GEHC, and he was compensated for participation in this podcast. The statements made by Dr. Golzarian described here are based on his own opinions.